The Healthcare Labyrinth podcast is back for another episode. Join Mark S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth podcast. My name's Mark Ryan. It's a pleasure to be hosting the podcast, and thanks to everyone for listening in. Today, we are going to be talking about Medicare Advantage special needs plans. Their growth is a relative bright spot for Medicare Advantage, so we wanted to sort of cover this topic. I went back and checked all our other 70 or so podcasts, and I determined I had never done one on special needs plans, although I have done some blogs about special needs plans. So we'll be deep diving on what SNPs are, why plans are investing in them, their history, regulation, and their future. We'll take 3 breaks, so we break this up in 4 parts here. Part 1 is really going to just tell you a little bit about SNPs and SNP investments. Part 2, we'll talk about SNP types and a little history. Part 3, we'll talk about regulatory trends in SNPs. And Part 4, we'll talk about the 2025 growth and some other statistics and characteristics. I would note that I had a recent blog on SNPs on March 24th. So you can go to healthcarelabyrinth.com, press the blog tab, and go to the March 24th, 2025 blog, and you'll see the SNP blog there. And there are some really neat graphics that explain a lot of what I'm going to go through now in more detail and give you a nice visual context. So go to healthcarelabyrinth.com, the blog tab, March 24th, 2025. So let's get right into the topic of the day before our first break. The Medicare Advantage industry is going through very tough financial times, as I tell you all the time. A variety of factors, including rate cuts, an increase in utilization, and a new risk scoring model force plans to reduce benefits and exit many geographies in 24 and 25. What MA plans did in 25 was shed unprofitable geographies and products, including more rural and suburban areas of the country and certain more expensive provider organization products. But along the way, MA plans have doubled down on special needs plan investments. While enrollment growth is coming down, and that's the truth on SNP enrollment too, the SNP enrollment in 25 was roughly double or more of what it was for MA overall. So notwithstanding the problems we see out there, MA plans continue to invest in these special needs plans along the way. So what are special needs plans? So very briefly, a special needs plan is basically a subset of other MA products. And these special needs plan subsets focus in on individuals with high needs to lower costs and improve quality. These SNPs have greater regulation than other MA plan types and require pretty significant regulatory and clinical investments. So the investment in SNPs is driven by a few factors. And after our first break, we'll talk about some of the SNP types, but let's just talk about some of the investment and why it's happening. So number one, the Centers for Medicare and Medicaid Services has sent a message that it will prioritize the further integration of Medicare and Medicaid and want to use SNPs in a major way. And so dual eligibles are often very large enrollment categories of these special needs plans. They have to be dual eligibles in one given type we'll talk about after the break, but even in the other 2 types, you have a lot of dual eligibles just given the characteristics. So this integration strategy from CMS will bring complexity and costs, but further the opportunity for plans that invest here. With the move to integrate the Medicare and Medicaid funding streams, health plans do not want to risk being left out of membership in either line of business. This includes the major focus in states on long-term care managed healthcare as well. So one of the reasons that MA plans are investing here is CMS is sending the message, we're going to go farther down this road of integration between Medicare and Medicaid. Number two, CMS is targeting a reduction in the disproportionate costs that dual eligibles drive in Medicare and Medicaid in improving overall poor outcomes for these populations. So it's sort of related to the top one of integration. Just one stat here, dual eligibles represent 17% of Medicare beneficiaries and 14% of Medicaid enrollees. But they consume about 33% of traditional Medicare spending and 32% of Medicaid spending. So basically, their consumption is roughly about double what their enrollment statistic is. This is what CMS wants plans to really tackle here. Number three, CMS has passed a number of regulations over the past few years that expand supplemental benefits. We talk a lot about this. They've expanded supplemental benefits for the chronically ill and those with social determinants of health. These benefit expansions are not specific to SNPs, usually, although some categories are. But MA plans are targeting many of these benefits to SNP plan benefit packages because they help reduce costs and improve outcomes. We'll talk a little more on this a little later. Number four reason for investments, there also are significant financial opportunities with SNPs, and I referred a little bit to this a little earlier. SNP membership offers much greater per member revenue due to various factors in the demographic portion of the rate setting system, for example, Medicaid status, frailty, and things like that, as well as the clinical HCC risk adjustment component. Dual eligibles and SNP members tend to have multiple disease states, so their clinical HCC risk factors are greater. Done right, because of this higher reimbursement, even beyond the high reimbursement MA plans already get compared to other lines of business, health plans can reduce costs dramatically against the fee-for-service cost as long as they practice good clinical oversight and address social determinants barriers for these SNP populations. If plans can reduce costs for SNP enrollees, the greater opportunity for margin. Next reason for investment, although MA continues to grow, again, as I noted, SNP enrollment has outpaced MA enrollment growth overall. So plans are looking to keep up with enrollment growth, and SNP products are a good way of doing it. And last, many of the plans are also in Medicaid and see natural synergies, including the spread of administrative costs between the Medicaid and Medicare lines of business. So in summary here, before our first break, SNPs offer MA plans the ability to improve health outcomes while also registering a healthy margin. But more and more SNPs are not for the faint of heart. Running a SNP product requires superb regulatory and clinical execution, as well as acute sensitivity to the ever-changing integration between Medicaid and Medicare. So with that, we'll go to our first break, and when we come back, we'll talk about SNP types and a little bit of history. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Mark Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Mark dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Mark is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Mark's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking about special needs plans. As I noted at the beginning, I've never done a podcast on special needs plans. I've referred to them, but not one very specific. So we've already sort of introduced the topic before our first break, and we talked about exactly what a SNP is and some reasons that plans are investing right now, especially in 2025's recent enrollment season. So let's talk and get back. I told you about what SNPs are. Let's talk about the 3 SNP types and give you a little history. So, as I noted, there are 3 types of SNPs. And again, dual eligibles can be in any of these, but they have to be a dual to be in one of them, as I noted. So our first SNP example is called an Institutional Special Needs Plan, or ISNP. In this case, the enrollee is a resident of a long-term care facility or at risk of institutionalization. While Medicare Advantage does not cover long-term care expenses that are chronic, they cover them on a short-term basis after hospital stays and things like that, this institutional SNP is really seeking to coordinate the primary Medicare medical services with what is Medicaid long-term care services that most of these individuals are in the community or in an institution. So that's the reason that Medicare Advantage has this concept of an institutional SNP. Again, it does not pay for the chronic long-term care, usually Medicaid does, but it does pay for the Medicare primary care, and it's really important to coordinate the Medicare primary care, Medicaid long-term care services, and if the individual is a dual eligible, the Medicaid other medical services that are provided under Medicaid to that dual eligible. Number 2 is what's known as a chronic condition special needs plan, or a CSNP, or sometimes called a CC-SNP. In this case, the enrollee must have one or more specific disease states from a list prescribed by CMS to enroll in a plan tailored to their conditions. And these disease states, I won't go into them in depth here, but they are the common disease states that most seniors and people with disabilities have. There's about a dozen in rough measure. And so again, the reason for chronic condition, or CSNPs, is that many of these individuals have multiple comorbidities, and therefore their cost profile is very high. And so this chronic condition SNP is seeking to lower the cost of care and improve quality among individuals, perhaps dual eligibles, but they don't have to be, but improve costs and outcomes in a very highly comorbid cohort population for chronic condition SNPs. Our third SNP is our dual eligible SNPs, or DSNPs. And in this case, the enrollee must be eligible for both Medicare and Medicaid, either partial or full dual eligibility, depending on the plan and what the state dictates and what the MA plan offers. It is often the case that those who enroll again in ISNPs or CSNPs can also be dual eligibles, but in the case of dual eligible or DSNPs, you must have some form of dual eligibility. Now you ask, why a dual eligible SNP? Well, they can have multiple comorbidities too, but one of the advantages of having a dual eligible SNP is, again, the ability to integrate Medicare and Medicaid, and the ability to focus in on the social determinants of health barriers that dual eligible individuals, which are usually low-income elderly or they can be low-income disabled, have. So as opposed to chronic condition SNPs, which are probably more focused on clinical, in the dual eligible SNPs, you may focus more on the social barriers to good health and the barriers that take away from, medication management and getting testing and things of that nature. There are also different types of DSNPs from an administrative standpoint. So basically, we're going to take our dual eligible SNPs now and break them into 3 types or subtypes of administrative DSNPs types. So there's a coordination-only DSNP, and in this case, plans have very basic integration with state Medicaid agencies, including some reporting requirements such as inpatient admission notification. States can dictate various levels of integration here, but again, it's softer and it's sort of coordinated. Plans do have contracts with states calling out their obligations to the Medicaid agency for these coordination-only administrative types of DSNPs. The next administrative type of DSNPs is called a highly integrated DSNP, or a HIDE. These plans have a contract with the state Medicaid program and meet the requirements of a coordination DSNP, but in addition, they must also have a Medicaid plan operating in the same counties as the DSNP that is being offered through MA that provides integrated long-term care services or behavioral health. In this case, the LTC or BH benefits usually are provided by a separate plan than the MA plan that is owned by a common parent organization. We'll call it a sister HMO in the state, usually with the Medicaid contract. The third administrative subtype of DSNPs is called a fully integrated DSNP, or a FIDE. These plans have a contract with the state Medicaid program and meet the requirements of a coordination DSNP. They provide Medicare and included Medicaid covered services through a single managed care plan organization. One plan, the MA plan, covers all of the Medicaid benefits as well as the Medicare benefits. In some cases, certain Medicaid benefits may be provided by the state or by a different health plan, but that's sort of an exception. Starting in 2025, FIDE SNPs may only enroll full benefit dual eligible individuals. So right now, some FIDEs have partial duals and things like that. Starting in 2025, they can only enroll full benefit dual eligible individuals if they're enrolling in both the FIDE SNP and the Medicaid plan sponsored by the same organization. And in addition, starting in 25, they must cover long-term care services and all Medicaid benefits. So this is a good example already of a regulation where CMS is trying to drive integration. They're using FIDE SNPs to have one plan pretty much take care of everything, including Medicaid long-term care services. So let's go to a little history on SNPs here before our next break. It was not long ago that SNPs faced extinction. CMS felt MA health plans viewed SNPs as marketing tools rather than specialized plans to improve outcomes and save costs. Only last-minute extensions of the program in Congress allowed SNPs to continue to be offered for some time. CMS began to come around and the program eventually was made permanent. At the same time, CMS only got comfortable making them permanent when they began laying out much more rigorous requirements and oversight for SNPs, all 3 types. This has led to the burgeoning of the SNP roles. D-SNPs dominate. They're about 80%, I'll tell you later, but C-SNPs are now seeing major growth as well. So with that explanation of the types of SNPs and the administrative subtypes and a little bit of history on the fact that they almost faced extinction, we'll take our next break. And when we come back, we're going to talk a little bit about some of the regulatory trends that are now popping up more and more from CMS on SNPs. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking everything about special needs plans and Medicare Advantage. We've told you that they're growing. We've told you a little bit about what SNPs are, a little bit about the history, and a little bit about the three types and the administrative subtypes of the dual eligible SNPs. So I promised to get into explaining some of the regulatory trends that are out there. I told you a little bit earlier that SNPs are not for the faint of heart, and they really won't be as we move down this regulatory road. I said before our break that CMS began getting comfortable with SNPs when they laid out more rigorous requirements and oversight. So we're going to talk about those now. So CMS really has honed its audit protocol and its clinical oversight objectives for SNPs. These are still evolving, but regulatory oversight has increased dramatically. SNP plans face close scrutiny in many areas, including health risk assessment completion, individualized care plan creation and issuance, the formation of an integrated disciplinary care team for each member to drive health outcomes, and aggressive risk and health status change tracking and intervention. So I told you it's not for the faint of heart, and there's a lot more requirements. So just to reflect a little more on this, while plans may do health risk assessments and have care plans and care teams for certain Medicare Advantage members if they're very high cost or very complex, it's not an absolute requirement for MA members outside of SNPs. But these HRAs, the individual care plans, and the interdisciplinary care teams are absolute mandates. And during a program audit, SNPs are looked very closely at all of these factors, including the aggressive risk and health status tracking and interventions that are required. So again, very, very important. Again, CMS is auditing against both the regulations in place as well as what is a required model of care that each plan must create and get approved by the National Committee on Quality Assurance, which is the entity that is designated by CMS to make sure, in addition to all these care plans and care teams and other mandates, that every plan also file and follow a model of care for their SNP, and NCQA approves it, and then CMS will audit on it as well. So again, very, very complex. CMS also has passed a number of rules that seek to closely integrate Medicare and Medicaid funding streams in clinical oversight. I mentioned this earlier. This is applicable to D-SNPs. Most D-SNP plans meet what is the coordination requirement we talked about earlier. CMS, though, would like all D-SNPs to eventually become far more integrated, including ultimately to have all D-SNPs be FIDEs or HIDEs, the most integrated of all of the D-SNPs. Such plans have numerous additional regulatory requirements across enrollment, care management, authorizations, appeals, and grievances. This is beyond even what I just outlined about care plans and HRAs. Such plans, the FIDEs and HIDEs, will see strong and robust state Medicaid requirements built in as well. CMS is also promoting the breakout of SNP contracts from plan master contracts so that SNP quality can be better evaluated. This could also lead to different STAR quality measures over time for SNPs. Right now, there are just a few additive SNP measures. Otherwise, the SNP population is evaluated within the overall membership in a given plan contract. Let's go a little deeper there. So a contract that is signed by most MA plans will mix regular MA plans in with SNP contracts, although some plans have SNP-only contracts. What that new regulation says is that states can tell CMS that it wants the SNP contracts to be broken out separately. So the contract of that plan is for a SNP contract only, and the other contract that now has both will only be the so-called mainstream MA plans. And this will be rolling out over the next several years. And so this is sort of a threshold event, because not only do you have deeper clinical and other program audit and regulatory requirements, but now your SNP contract moving into the future, when it is split out as a standalone SNP contract, you will really, as a SNP, have to look closely at your quality achievement. Right now, it's a subset of your overall achievement, and it's possible that your SNP achievement could be lower. So when these SNP contracts get broken out, you really have to drive quality in addition to all those other compliance, regulatory, and clinical requirements. Next, regulatory trend, CMS has encouraged a heavy focus on social determinants of health. This is most important with SNP populations. CMS looks to SNPs to screen for such social barriers and mitigate them to promote better health outcomes. Some studies suggest that social barriers can be a greater determinant of health outcomes than underlying disease states. Whether the focus will change with the return of the Trump administration is an open question. Trump already has pulled back on the focus on SDOH waivers in Medicaid. But in general, even if there is some pullback here, attention to social determinants of health will be very important in SNPs nonetheless. CMS has also sought to rein in what it sees as continuing abuses by MA plans in the market related to dual eligibles, as well as to foster further integration with Medicaid, as we talked about. Recent rules adopted or proposed include the following. Changes were adopted to rein in more liberal dual-eligible special enrollment periods to allow enrollment only in integrated SNPs if outside the regular enrollment periods. Changes were adopted to limit the number of D-SNP plan benefit packages an MA organization can offer in the same service area as an affiliated Medicaid MCO. This last stipulation also would apply to a parent organization or entity that shares a parent organization with the MA organization. Changes were made also to reduce the number of D-SNP look-alike plans. These were plans that had benefits that looked a lot like D-SNPs, but they weren't filed as D-SNPs and didn't have to follow all the rigorous regulatory requirements. While applicable to all plans, SNPs also need to perform outreach efforts on promoting the availability of supplemental benefits, create an individually customized mid-year analysis of supplemental benefits that were used and not used, and furnish to CMS evidence-based clinical criteria when proposing chronically ill supplemental benefits to ensure the benefit has a reasonable expectation of improving the health or overall function of chronically ill enrollees. Again, supplemental benefits are not just SNP benefits, but they're very important, so SNPs have to look closely at them. Changes were recently finalized for 2026 to simplify healthcare access for members of an applicable integrated special needs plan, an AIP SNP. These AIP SNP plans can be coordination-only SNPs, HIDEs, or FIDEs, but enrollment on the Medicaid and Medicare side match up exactly under agreements between plans and states. In 2026, the rules will require integrated member identification ID cards that serve as the ID cards for both the Medicare and Medicaid plans in which an enrollee is enrolled. In 2026, the MA plan will also have to conduct an integrated health risk assessment for Medicare and Medicaid. So with that, we are going to take our third break, and we will come back and talk about enrollment growth and just conclude a bit. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Mark Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Mark's insights. Twice a week, Mark publishes a blog to go deep into a current issue. And of course, Mark hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Mark's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking everything about Medicare Advantage special needs plans here. We've talked about regulations. We've talked about why plans are investing, the types of SNPs, the subtypes of SNPs, and things like that. We're going to sort of end the podcast coming up now on the enrollment growth in 2025, just to give you a feel for did the investments that MA plans were making in SNPs pay off. Well, as of March 2025, SNP and related program enrollment stood at 7.586 million lives. That is 106% growth since January 2020, when it stood at just 3.687 million lives. This is an increase of 3.899 million lives. This includes all three SNP types, as well as the Medicare Medicaid plans, which is a fully integrated pilot, much like a FIDE. That pilot will sunset as of 12/31/2025, when most states will convert the membership to either HIDEs or FIDEs under the main MA SNP program. As a comparison point, overall MA growth has been a robust 47% since January 2020, but SNP growth is well more than double that. D-SNPs account for 6.060 million as of March 2025, or about 80% of all SNP enrollment. 83% if you include the MMP lives. This is up from 2.833 million in January 2020, an increase of 3.227 million, or 114%. C-SNPs have seen major growth as well, moving from 369,000 members in January 2020 to 1.161 million in March 2025, an increase of 792,000, or 215%. I-SNPs have had a much more conservative growth since 2020, just 23%. Growth of MA overall from January 2024 to March 25 was 4.8%, compared with 9.8% for SNPs during that same time frame, January 24 to March 25. Overall, SNPs now represent about 21.6% of all MA enrollment. Milliman reports the following on the administrative SNP types. Coordination-only plans represent approximately 65% of D-SNPs, while HIDE and FIDE plans represent approximately 27% and 8% of D-SNPs, respectively. For the first time since 2021, the percent growth in coordination-only plans, 7.9%, was smaller than the growth in HIDE SNPs, 8.2%. FIDE SNPs offerings remain relatively flat. What has MA's recent contraction done to SNPs? CMS says in 2025 the number of MA plans overall decreased by 2.8% in terms of offerings, including a 6.5% decrease in individual MA plans, but an 8.5% increase in SNPs. So SNP products continued to increase while MA plan offerings overall decreased. The availability of SNPs varies by state, with an increase in the number of SNPs in 29 states and a decrease in 7 states and Washington, D.C. in 2025. The contraction in those states was related to the financial issues in the industry, as I noted. Actuarial and consulting firm Milliman has done a good job on tracking SNPs over the years as well. Two recent reports that they did were in December of 2024 and in March of 2025. They gave a couple of observations to tie a bit back to what I said. First, they say SNPs are growing, but product and enrollment growth is slowing. They say that national plans dominate, but their footprints are shrinking. Rich D-SNP plans shrunk in 2025, and the so-called D-SNP value added changed considerably between 24 and 25. Milliman says the total value added shrunk by about $15 per member per month, mainly due to benefit degradations in the Part C medical benefit. There was a value-added growth of about $27 and $44 PMPM from 22 to 23 and 23 to 24, respectively. The benefit pullback ties to the financial crisis and contraction seen in the industry for 2025 and bucks a growth trend of at least 10 years. In terms of supplemental benefits, another group, the Better Medicare Alliance, reports that there were cutbacks in both regular MA plans and SNPs due to the financial crisis in the industry. Importantly, though, the percentage of SNPs offering at least one SSBCI, that's that supplemental benefit for the chronically ill, increased from 66.2% to 86.8%. There was a slight decrease in the percentage of individual plans offering SSBCIs. 15.8% of plans will offer at least one compared to 16.4% in 2024. So again, you saw supplemental benefits contract in MA overall, in individual MA, and in SNPs. But there was some brighter news anyway in terms of supplemental benefits for SNPs in 2025. Let's last talk about SNP winners and losers in 2025. Well, Modern Healthcare did a decent little study and graphic that told us about the winners and losers in terms of SNPs in the recent enrollment season 25. United Healthcare and Elevance Health, which were very bullish on 25 growth due to better financial positions, gained SNP lives, while Humana, Aetna, and Centene, which were all financially troubled and contracted a great deal, lost SNP lives. So with that, we've sort of come to the end of our look at all things Medicare Advantage Special Needs Plans, and we'll conclude this episode of the Healthcare Labyrinth podcast. We'll see you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.